Thank you, Kathy, and welcome everybody. Before we begin today's Friday feature, I want to invite you all to think about and send in suggestions for our Friday features. Let us know what you'd like to learn more about. You can email your suggestions to dg@5960.link. I just put that link in the chat box, so you can snatch that, and we look forward to hearing from you. Today's feature, COVID-19, The Path Ahead, is going to be presented by Tracy Sides, who is a public health policy analyst and consultant. She has a master's in public health, master of public health degree in epidemiology, and a doctorate in environmental health sciences from the University of Minnesota Public Health. Extensive experience in a variety of public health settings that I know she's going to touch on in her talk. Please direct your questions for Tracy into the chat box, as we normally do, and we'll get to them during the Q&A session at the end of Tracy's presentation. Thank you. Tracy, it's all yours.
All right. Well, first things first, I'm going to do the technology magic, and hopefully you can see. Let me get this going here. And just to confirm that you can see my slides.
Yes, yep. Looks good.
Great. Excellent. Thank you. And thank you, Ed. So it's an honor to be with you all today, and I really do appreciate the invitation to share. Before I begin, I want to acknowledge that what I'll share today was prepared and grounded in the four-way test as a Rotarian. And it's also based on what I understand to be true as someone who has worked for years as an infectious disease epidemiologist and public health professional. So a little more about my background. These days, as Ed mentioned, I work for the Public Health Law Center, providing expertise on epidemiology and policy related to commercial tobacco and health equity. Previously, I spent 5 years at the Minnesota Department of Health in the Infectious Disease Division, primarily working there on HIV. I also spent 6 years working with Mike Osterholm and crew at the Center for Infectious Disease Research and Policy, where I worked on bioterrorism, preparedness, planning, and response, as well as pandemic avian influenza. On a more personal note, I've lived in Minnesota for more than 25 years and moved here to the Twin Cities to attend graduate school. And one not so well-known fact about me is that I actually enjoy epic physical challenges, which are always also epic mental challenges. And in the early 2000s, my sister and I got to know Minnesota up close and personal through the Minnesota Border to Border Triathlon. And this is a 4-day event in which we biked, ran, and canoed between Laverne in the southwest corner of the state to Crane Lake up at the Canadian border. And I partly bring it up because I can't tell you how many times I've fought back to the mental challenge of that long haul over the course of this long haul of the epidemic, and thinking about those real mental challenges in navigating that. So here we are now with hopefully after today, 2 vaccines with emergency use authorization and others in the pipeline. So there really is a light at the end of the tunnel. And in this border to border analogy, essentially we're in that 50-mile canoe stage of the race, and we need to keep paddling to get to the finish line. So just a few presentation housekeeping items, if you will. So my objectives for today, what I hope to accomplish, are that you'll walk away from our time together with a deeper understanding of the significance of terms like COVID infections, case counts, hospitalizations, and deaths, that you'll feel more informed about the vaccine development process, safety protocols, what to expect on the vaccine path ahead. And lastly, that you'll feel inspired or at least more confident in being a source of information and resources for others in relation to COVID. I do have a few disclaimers as well. I have a doctoral degree in public health, but I am not a medical doctor. So please do not take what I say today as medical advice. Also, anything that I may say about the future is just my informed guess or the informed prediction of other experts whom I trust. And it also cannot be said enough that the situation we are living through is the greatest public health crisis since the 1918 influenza pandemic. And in this short time that and the SARS-CoV-2 virus has been with us, we have learned so much, but there is still a lot we don't know. And this understanding, as I mentioned before we started, just evolves daily, which made it a little challenging to prepare for today's presentation. And lastly, just to name that I tried to aim for the middle ground on how technical the information that I'll share in my presentation is. This is kind of a new day for epidemiologists. There's never been more coverage in my career and popular awareness of the field of epidemiology. I can remember in the past being asked what I did. And I kid you not, more often than not, after answering what I did, I would then be asked, epidemiology, that's skin, right? And I would say, no, it's the study of epidemics, not the epidermis. So that confusion really doesn't happen anymore, but it does lead me into wanting to highlight just a few terms for sake of clarity and how I use them. So I often explain that like a medical doctor treats an individual who's sick, epidemiologists focus on disease at the population level. And public health is a very broad field, generally involving local, state, or national government efforts, definitely in partnership with nonprofits, academic, and private institutions, but all with the mission to protect, maintain, and improve the health of the overall population. And in all states that I'm aware of, this is actually written into law as duties of the government. So what we're talking about today, COVID, is a devastating and lengthy worldwide health crisis with heavy and disproportionate social, mental, and physical health impacts. As of the 16th of this month in the US alone, we'd recorded more than 300,000 deaths, more than 17 million cases. And that includes, just on Wednesday alone, more than 245,000 cases reported just on that day. And in fact, already over the course of 2020, the average life expectancy at birth in the US has decreased by a full year. And this has not happened since World War II. As another comparison, during the height of the opioid crisis, kind of in the middle of the 2010s, that impact on deaths decreased the life expectancy by 0.1 year. So we're talking already, an order of magnitude difference. And we're looking at numbers on a graph right there, but the reality of the situation can be very harsh. The photo that I hope you're seeing on the left is off the coast of the Bronx in New York earlier this year, where they were building mass graves on public land to accommodate the overwhelming number of dead bodies. And the couple on the right are two healthcare workers who are mourning the death of the woman's grandmother in the hospital bed there. And I want to make a point of the fact that a lot of what I'll talk about from an epidemiological standpoint will be a little abstract, but I think that it's always important to remember that every case, every hospitalization, every death happens to a person, somebody's mother, father, sister, uncle, a friend. The other foundation, if you will, that I want to lay before launching further into things is just to lay out this concept of a scale of action or impact. And really this should be more of a nested visual. So from that cellular level, kind of building out to the systems level. And I hope to draw the connections between these scales by next providing a high level overview of what is happening to a person when they contract the viral infection and progress through disease at the cellular and the individual level, at least what we know so far. And this description of the disease progression is sometimes referred to as the natural history of a disease. And SARS-CoV-2 is this new agent to us. And again, it's remarkable how much we've learned and how much we don't yet know. But I do think remembering what is happening between exposure and progression of the disease process over time helps highlight the public health picture and challenges that we face at the population and systems levels. So just to unpack that systems level piece briefly, what I'm referring to there is the public health, the clinics, hospital beds, ICU rooms, personal protective equipment, other supplies and equipment involved in healthcare. And also, of course, the healthcare workers and public health staff themselves who provide the care and who will be have started providing vaccinations. So a brief description of the natural history. So the COVID-19 is the disease caused by the SARS-CoV-2 virus, and all viruses are intracellular parasites. Here on the left of this electron microscopy, you can see the small, there's small black round viral particles actually in vesicles within that large host cell. On the right side of that image, you can see viral particles that are just outside the cell, right near the cilia there. So viruses generally are, as I mentioned, obligate intracellular parasites. So they can't live very long outside a host. They can't replicate outside of a host cell. They are usually quite particular both about the species and the type of cell that they invade. So this relates heavily to the modes of disease transmission. So polio, for example, prefers cells in the gastrointestinal tract of humans. Viruses shed from there, so we have the so-called fecal-oral route of transmission is at play. And so poliovirus is primarily transmitted through contaminated food and water. SARS-CoV-2 prefers certain respiratory tract cells, and it's primarily spread through respiratory droplets and aerosols. Once a person is exposed to the virus, they may or may not, there may or may not be enough virus to actually cause infection. And by that, I mean like ongoing virus replication. So the so-called infectious dose of virus exposure will vary from person to person. The smaller the amount of virus needed to invade and start replicating, the more infectious the virus. We're still learning about this aspect of COVID, but the virus does seem to be notably more infectious than seasonal influenza viruses that we typically see. Also more than other previous coronaviruses that we've seen. So the COVID virus gets into the cell, evades some of the non-specific or innate immune response that the body naturally starts to produce when it encounters foreign invaders. So the virus gets set up, hijacks the host cell's machinery to produce lots and lots of copies of itself, all of which can go on to infect other cells. And during this time, a person is infectious, but they are not experiencing symptoms. This can go on for a variable amount of time, but usually 4 to 5 days typically, but as many as 10 to 14 days before symptoms develop. Mask wearing and social distancing can help minimize the amount of virus such a person would be putting into the environment around others, so helping to decrease the potential for transmission. But of course, it's not perfect. And at this stage, such a case is not visible, if you will, in our disease surveillance systems. It's not until someone is actually tested that they can be counted as a case. So a person may remain asymptomatic, or they may go on to develop mild to severe symptoms. Symptoms vary from person to person, but often include common respiratory upper and lower respiratory illness signs and symptoms, such as fever, cough, congestion, headache, body aches, shortness of breath or difficulty breathing. And nausea, vomiting, or diarrhea are also a common presentation as part of this. And fairly unique to COVID is this loss of taste or smell. So perhaps at this point, a person seeks out, now that they're feeling symptoms, they seek out a COVID test. And hopefully when they, while they think they may have it, once they know they have it, that they're isolating themselves and letting any contacts know about their diagnosis. So they may, mild enough cases may recover at home. But one of the phenomena we're learning more about are the so-called long haulers. So these are people who develop symptoms, just even mild symptoms. Maybe they just lose the loss of taste or smell or have fatigue. But rather than having them resolve over a couple of weeks' time, the symptom actually lingers for months. And it's not fully understood what is going on with this, or if and how infectious a person may be during this extended convalescence. But it seems to be kind of a unique feature of these long-term, potentially long-term sequelae from the disease. So again, there's still much that we have to learn. So I'm going to pause now on this natural history of COVID, where testing is most relevant to this story, or where we first encounter it. So as you can read on this slide, there are definite benefits of testing to both the individual and the population. And testing itself does require costs of healthcare and laboratory worker time, supplies, equipment. And again, it's pretty amazing that diagnostic tests were rapidly developed and our testing capacity ramped up for a new agent so quickly. Having said that, of course, we did encounter some notable bumps along the way and slowdowns, but still remarkable that we are where we are now. And in fact, just last week, the FDA approved the first at-home diagnostic tests that will be available without a prescription. So where are we in terms of cases in Minnesota? As you probably well know, the Minnesota story right now is quite different from the nation as a whole, and many other states. So our epi curve in the upper left there for new cases, while definitely still relatively high and higher than it's been at any other point in the pandemic, is trending downward. Hopefully this will continue, and the December holidays will not produce a surge within this surge that we're experiencing and the whole country is also facing. And just to draw attention to this curve, these cases, we're largely looking at infections that would have occurred in the past 2 to 8 days. So people who have been tested because they thought they may have been exposed or know they may have been exposed to someone who has COVID, or symptomatic cases. And these will be the pool of cases from which in about 7 to 14 days, we'll see those hospitalizations and deaths that are occurring as a result of those infections from about a week ago. So just to point out, this is California, Pennsylvania, and New York, and really difficult trends that they're seeing, and is reflective of the nation as a whole. The other point that I think is important is the notable disparities in the incidence of cases. These are Minnesota data among Black, Latinx, and Native Hawaiian and other Pacific Islanders have a very high rate. So these are rates within the population, not absolute cases, but to demonstrate the disproportionate impact and occurrence that the disease is having in our different groups. One driving reason for this is that communities of color have increased exposure to the virus by virtue of working in jobs more often that are now considered essential, such as childcare, grocery stores, meat packers. Fortunately, these are also jobs that are typically underpaid, often lack health benefits, and even worksite protections. And then moving to some of the available graphs on the Minnesota Department of Health and the state's COVID-19 dashboard, you can see that these indicate on the left that we still have a very high concerning amount of new cases, again, with the trend in a good direction. And on the right, also of concern, is that more than a third of new cases report no known exposure. So meaning that community spread is still widely occurring. It's not pictured here, but our positivity rate, the number of positives per number of tests that are done, is still at about 10%. And we'd really like to see that below 5 to feel like we have a handle on keeping new cases in check. So the vaccines are on the way. They're getting rolled out, but back to the border to border analogy, we definitely need to keep paddling. We need to keep doing what we can by staying home if we can, wear a mask, stay 6 feet apart, avoid crowds, wash our hands. And I'm going to turn now back to this natural history story. And where we left off was the mild and moderate cases of COVID, which can recuperate at home. But as you can see in that tip of the iceberg picture, about 15 to 20% of cases seem to go on to develop severe or very severe disease. And this typically happens within around 7 to 10 days after infection. And when this occurs, the deepest part of the lungs are infected. And this is the alveoli, those little air sacs where gas exchange is taking place. And the infection can cause extensive damage and infiltration of those sacs, and fluid can be introduced. So these patients are hospitalized. Some of them require intensive care. About 2% of cases die. This is the case fatality rate that we're seeing overall right now. More often, but definitely not exclusively, the most severe cases and deaths occur among older people, those with underlying health conditions. But again, that's not exclusively. We see these severe cases throughout the ages. And unlike influenza, young children seem to have milder or asymptomatic infections. Now, having said that, there is a very rare but serious complication of COVID that is being seen in some children. Again, rare, but it's unique and troubling. It's multi-system inflammatory syndrome. And in this, different body parts can become inflamed, including the heart, lungs, kidneys, brain, skin, eyes, or gastrointestinal organs. There, again, is just a lot that we have yet to learn about this disease. So treatment in hospitals definitely helps save individual lives. And so therefore is also contributing to the overall public's health. Presumably recovered individuals with a healthy immune system will also help the population by no longer being able to serve as a source to further the virus's spread. How long or durable this immunity is, again, remains to be seen. One of the big system issues that we need to be concerned about in relation to treatment is the danger of overwhelming the capacities of our healthcare systems as the severe, in particular, severe cases or hospitalized patients surge. So this is of particular concern in the coming months as we're rolling out vaccine and standing up vaccination clinics. That is also going to require costs of time, resources, people in our healthcare system. And so preserving our healthcare system capacity while we're rolling out the vaccine is really important, and one of the many reasons, but an important reason why getting a handle on transmission is so important. So back again now to how are we doing in Minnesota right now? Like with cases, the Minnesota story is very different from the nation as a whole and many other states. For example, right now in California, the governor has activated what's called their mass fatality plan. This involves identifying and staging extra refrigeration storage, extra body bags. They are, many of their hospitals are at 100% capacity, including ICUs. So it's a very grave situation in many parts of the country. Here in Minnesota, we are, again, like with our cases, at the highest hospital numbers of hospitalizations and ICU rates as we've seen in the pandemic. But again, for now, these are trending downward. And when we're looking at these hospitalizations and ICU admissions, we're now looking at infections that would have occurred in the past 10 to 14 days or more. And as we saw, the cases appear to be trending down. So we can hopefully expect to see further reductions in hospitalizations. And again, hopefully the December holidays will not produce a surge of new cases and hospitalizations, just as we're looking to ramp up a vaccine rollout. Again, I do want to point out that the stark disparities that we saw in case occurrence is actually it's more pronounced in the occurrence of severe disease and death, particularly among Native Americans and communities of color. And this is, as a result of systemic disparities, these groups are at higher risk of multiple health issues such as diabetes, heart disease, severe asthma, and obesity. And these underlying conditions put them at higher risk for severe illness and death. That does not even include the other kind of socioeconomic and other social determinants of health that create greater vulnerability for these populations from COVID-19. On the left, you can see rates of hospitalization. I didn't include the ICU admittance, but they mirror these data. The rate of hospitalization is lowest for white individuals. Indigenous, Black, and Latinx individuals have the highest age-adjusted rates of death, which is the graph there on the right. So as we return now to the natural history story, we'll give this one a happy ending. A person has recovered from COVID. So for people that recover, as I mentioned, they will have developed a specific immune response to SARS-CoV-2. For how long, again, we don't know yet. Now, on the right, vaccines also can confer this specific immunity. But instead of active acquired immunity, like the recovered patient, when it's immunity developed from a vaccine response, we call it passive acquired immunity. And with highly effective vaccines, the immune response generated will prevent disease or severe disease, or prevent disease altogether, or at least severe disease in individuals. And the great news on this front is that today, possibly while we're here right now, a second highly effective vaccine is expected to receive emergency use authorization from the Federal Drug Administration. So both Pfizer and the Moderna vaccines were found to be safe, and actually both were 94% effective in large clinical trials. Not surprisingly, about 15 to 20% of people reported sore arms and some minor side effects, pretty similar with what we see with other vaccines. What we don't know is if the vaccine also prevents infection. So someone who's received the vaccine, but they get exposed, can the virus reproduce and shed without causing disease, but that person may still be infectious. So what we don't know is, do the vaccines actually prevent transmission as well? There is another vaccine candidate in the pipeline made by AstraZeneca, which is in phase 3 clinical trials. They are also doing additional testing of individuals along the way, looking for virus shedding over the course of their study to examine that question. At least for their vaccine, can it also prevent transmission? The two that are, let's say that they're both approved. So these two vaccines, Pfizer and Moderna, are messenger RNA or mRNA vaccines, which is a newer type of vaccine, but it has it's a technology that's been developed over the past 20 years. The one trick with mRNA vaccines is that bit of key material, the mRNA itself, is quite fragile. And this is the reason for these extra cold temperatures that the vaccine vials must be stored at. So this is -94 degrees Fahrenheit for the Pfizer and -4 degrees Fahrenheit for the Moderna. So this adds a logistical complication to the vaccine distribution and delivery system. Another logistical challenge is that initially the supply will be limited. The good news on this is that it's been really thoughtfully considered by a few groups, but in particular, the U.S. Center for Disease Control's own advisory committee on immunization practices has thoughtfully considered this and has made recommendations on allocating these initial supplies. Their framework and their recommendations are both ethical and practical. These recommendations read as if ACIP used the four-way test to generate them. And in this initial rollout, this initial phase, 21 million healthcare personnel and 3 million adults residing in long-term care facilities are prioritized to receive vaccine. As the supply ramps up, additional key groups, including essential workers, people over 65 or with underlying conditions, will then become eligible. Perhaps by May or so, the vaccines will be available. That's probably the earliest they'll be available to the widespread healthy general population. So there has been extensive rigor for safety and efficacy that's gone into the development of all of the vaccines, but for sure the two that have received their emergency use authorization. But these are still new, and they were developed remarkably quickly. And during a highly political and emotional period. Unfortunately, it was done without a lot of public explanation to help generate awareness and understanding of the process, to help build that foundation of trust. But it's financial risks and not safety risks that were taken in order to speed this process. Nonetheless, it's not that surprising that in public polls over the past months, considerable vaccine hesitancy has been documented, especially, unfortunately, among groups that are at some of the highest risk for COVID and severe disease. The good news is that the acceptance appears to be increasing. So the Kaiser Family Foundation has routinely been doing some polls examining this question of perception vaccine hesitancy. You can see that over the past few months, the acceptance has increased, that now in December, 71% would probably or definitely get it. As part of these surveys, they also ask why. And so you can see here a list of the variety of reasons for vaccine hesitancy. And this varies from different group to group, groups of between race, ethnicity, or a social identity. The reasons for vaccine hesitancy vary. This list here that you can read over is in the order of frequency. So the most often given reason is worried about possible side effects. But you can see there also hesitancy around trust in the process is also up there. As I mentioned, these different groups have different levels of hesitancy, different reasons for hesitancy. This graph is depicting in the very middle is that 27% overall total in the survey population, which is intended to be representative of the US population. But overall, 27% indicate that they probably or definitely would not get it. And so above that line, you can see some of the groups that respond with more vaccine hesitancy. So specifically, for example, 1/3 of Black adults and essential workers surveyed said that they probably or definitely would not get a COVID vaccine. One group I also want to highlight in particular is the hesitancy expressed among healthcare workers at 29%. This is an especially important group because they are among the most trusted sources of information on COVID vaccines. So the good news is we've come a long way on this journey to a vaccine. We've developed some effective, safe vaccines to prevent death and disease, but this last inch, this getting vaccines into people's arms as the vaccine supply ramps up may be the hardest part of the journey. And vaccines just, they won't do us any good unless they get into people's arms. And all Rotarians through the whole polio experience, I'm sure can very much relate to that. So a few takeaways just to highlight here. There is one other point I do want to make about vaccines, and that is that, you know, regardless of vaccines, bad things happen to people every day. And adverse events that occur among vaccine recipients, whether in clinical trials or in community vaccination clinics, these potential adverse events are being and will continue to be monitored. There's a quite robust adverse monitoring system for vaccines. So, and we've heard about some of these that have come up, and that's good. That type of transparency of the reporting, the investigating, and identifying if the course of action needs to be altered. An example of this is when the vaccine began to be rolled out in the UK, there were a couple people who had severe, moderate to severe allergic reactions. And so an update to what are called contraindications or conditions and reasons why people should not receive the vaccine is highlights this history of severe allergic reactions being a reason to not have vaccines. So the other piece to point out is that this is also something we're concerned about with any vaccine, and why people after receiving one in a clinic are, you know, asked to remain there for 15 to 30 minutes in case they develop a severe allergic reaction and care can be provided. So, bad things can happen, but bad things are going to be happening. And I think that there's, we need to expect that. And because there is a real danger that social and other media can overreact to what are perceived adverse events. So one example to demonstrate this is if we were to vaccinate 10 million 55 to 64-year-olds today, in the coming 7 days, actually regardless of vaccine, but now they've received vaccine, in the coming 7 days, we would expect among that group 793 fatal heart attacks, 736 strokes, and we could list other bad things that happen on on a daily basis. So because trust can be so easily broken, I'm just really hopeful that misinformation does not derail the vaccination effort. So as I mentioned, I will share a copy of the slides. These are, so you'll have access beyond just being on the screen right now of some of these URLs that are just some of the regular resources that I look to. I do highly recommend that the weekly podcast that Mike Osterholm does. I find it a really useful way to stay on top of what's happening. If you're a nerd like me, you might enjoy seeing in greater detail that second from the bottom is a, it kind of goes through the physics of airborne transmission or swapping air with some fancy camera work. And that last item is a large cohort study that was published earlier this week in the British Medical Journal that does a nice job of documenting differences in disease severity and risk of death between seasonal flu and COVID-19. They really are kind of different animals when it comes to their impact on individuals and the public's health. And lastly, just huge thanks to former colleagues, current staff at the Center for Infectious Disease Research and Policy and the Minnesota Department of Health, and really all healthcare workers. Deep gratitude and Godspeed, and keeping on paddling themselves. So I will stop sharing. I went a little longer than I intended. I apologize for that, but I'm happy to answer whatever questions I can or point out resources where we can find the answers if they exist.
Thank you, Tracy. We've had a number of questions submitted, so we'll try and parse them out a little bit here too. One I think might be good to start with is somebody asked, Newell Krogman asked, could you explain the concept of herd immunity?
Sure. So I wish I had a little video that could display this, but herd immunity is referring to the concept of if you have, let's say we had a population of 100 people, and if 70 of those people are immune, either through having recovered from COVID-19 or having been vaccinated. If you picture this, this box of 100 marbles, and as they're circulating and virus is introduced, there's a case of COVID-19. During that period of infectiousness for that case, when that infected marble interacts with an uninfected marble, the virus, the disease, can be transmitted. And so as the number of immune marbles are present, when that density of immunity in a group of people, or marbles in this case, reaches a certain level, the likelihood that that virus can move about freely between uninfected people decreases. And I mean, and there's kind of like, and again, I wish I had it's really kind of a mathematical issue. And so looking to have, and no one knows exactly for sure with COVID, 50 to 70% of people to really have that kind of dynamic stopping power where the virus cannot be passed along in the population is what is being hoped for. But what we've seen so far in the past, there's been some suggestion that, oh, maybe it's just 20%, but it's not playing out that way. And mathematically, it looks like it really needs to be a higher percent of the population who are immune to being able to be infected and therefore to be able to pass it along. It's sort of like the number of rods in a nuclear reaction. We want to slow that reaction down. So.
Okay, thank you. Ed James asks a question. And, given that we've got now hopefully 2, as of today, vaccines that are based on the messenger RNA, which is sort of this new technology, my understanding, he's asking what you might be able to tell the group about a new strain of COVID-19 that's been discovered in the UK. What's the possibility that the current vaccines will not protect against a new strain? So is it, well, like the normal flu, we need to get a new flu shot because it keeps morphing each year. We're going to face a similar thing with COVID-19, do you think?
Yeah, that's a great question. And I'm not familiar with the this exact new strain, and so I don't know how different it may be. What I can say is that on the one end, in terms of the amount of genetic variability a virus has, and therefore its ability to rapidly evade immune responses, whether vaccine or disease-wise, on the one end, we've got HIV, and that is one of the most genetically variable viruses. It's why we, still don't have great vaccines for HIV. On the other end, we've got things like rabies, other things that are just very solid. Their genetics don't change that much. In the middle, if you will, is seasonal flu. And like you pointed out, this is something that's changing season to season. We really don't know what to expect. The early indications were that it is coronaviruses do not change that rapidly. I would expect that if anything, it would be like seasonal flu, as opposed to turning into like an HIV situation where, we're in a bad situation in terms of keeping up with vaccines. The good news is that we've got all of this capacity in terms of the vaccine development, the vaccine production. We're in a good position to be able to respond if and as additional strains are introduced.
Thank you. Lynn Thoraldson asks, has a kind of interesting viewpoint. He says, we have a God-given immune system, one that has been severely compromised by GMO science, some of the new foods that are getting morphed. Why has there been no emphasis on such, and how to improve the immune system by what is consumed, including proven vitamin supplementation? There has been mention of vitamin C, D, and zinc, but that is about it, and even that gets very little promotion. Any thoughts on? I guess that gets more nutrition and, but.
Well, I think it's a good point. And, when I had that slide up about the definition of health, from the World Health Organization, and that physical, mental, social, all of these other aspects of supporting our own robust immune system, these host factors that can make us more susceptible to disease or to severe disease, because of the I think being the systems, public health systems and such, being overwhelmed trying to respond to the cases, that has been overlooked. But I think it's a really good point as something that we can all do in terms of taking care of ourselves as a means to also bolster our resilience in the face of an exposure.
And Glenn Bowers put in here, I guess he's heard something on this new strain in the UK says it has something like 16 to 18 point mutations. And then Jim Hart says that he's watched a very good seminar yesterday, during which an MD from Florida said that the minor mutations of the spike protein will most likely not make the vaccines ineffective. And he goes on, he says, and then he made another comment, I know of no evidence that GMO foods affect the immune system. So there's, the debate goes on, I guess, with some of this.
Yeah. That'll be another Friday feature, maybe.
And I actually got my PhD in virology, so.
Okay.
Glenn, you're up next with a Friday feature.
There we go. But I do want to thank you. I guess it was Jim maybe who passed along the more detailed information about the UK strain, and that makes a lot of sense. So hopefully at worst, it's the vaccine would have sufficient efficacy to at least continue preventing severe disease, if not also helping prevent infections itself.
Richard Wilson has an interesting point. He says, healthcare workers is a broad category. Are there efforts to drill down to understand which healthcare workers are vaccine reluctant? Is it a specific group, or is it pretty much widespread, or do we even know?
That is also a great question. It's a broad brushstroke to just say healthcare workers. I don't know the details. They may be out there, but I do know from other more anecdotal information that I've heard from people in contact with physicians and nurses that there is hesitancy that they've heard spoken to in that group. So, but I don't know the specific details, but it's an important point.
Okay. And Richard Wilson also cited something else here. Are epidemiologists looking at the effect of COVID on diagnosis and treatment of other diseases such as cancer? And he says, I've heard about cancer rates dropping due to lack of access to medical care. And I'm not sure quite what he means by that.
Well, I'm not totally sure either, but this is what I'm hearing, that I believe that there are people trying to look at this question of the impact really of COVID on our healthcare and public health systems in maybe decreasing the other vaccines that would normally be happening, decreasing not necessarily the incidence of cancer, heart attack, other things like this, but decreasing the level of sought medical care and diagnoses. And so, I think I think that's happening, and I think it is evolving as to developing our kind of real-time understanding of how that's playing out, but it is definitely a concern. And that reminds me, I know, Ed, you talked about that letter that you'd gotten from RI, and the issue of, yes, we need to maintain this push to eradicate polio and get those vaccines out there. And we've got a house on fire. We're trying to deal with COVID. And so there are going to be some real collateral impacts of the pandemic too, that we haven't even yet fully described.
And I think that could be a function, Richard's point about the reduced rates, as you're saying, could be a function of people just reluctant to seek out medical care at this time for fear of contracting COVID. I've often heard one of the worst places you can go, one of the easiest places to get sick is to go into a hospital because they've got everything else floating around in there. One more question, I think, and we'll maybe call this to an end. And but before I get to that last question, which I thought was kind of interesting, I got to find it again here. Oh, it should be right here. Hold on. Carol suggested maybe some of these questions we could send on to you. You could maybe answer, and we could send it out to the group a little bit later on when you've got, you know, some time, if you're willing to do that. Where's that question? Come on. Oh, come on. Oh, here we go. And this is from Kay Baker. She says the latest rumor on COVID. Okay, apparently pharmacies aren't selling much Tamiflu, and you don't hear much about flu numbers. Could some of the false positive tests just be the flu? And that's what's making the rounds on Facebook. One thought I would throw in there before you answer is, I recently read in the Star Tribune that the number here, at least in Minnesota, the number of folks complying with mask wearing out in the public, and that is up to like 95%. And I'm thinking that is probably having an impact on the flu season because we're not spreading those germs either. So, but if you want to
absolutely. I mean, these sort of infection control measures that we've all been hopefully a lot more regimented about adopting is not just preventing COVID transmission, but all, you know, regular cold and seasonal influenza. I'm not aware about of the rumor related to false positives. One thing is that it's challenging because our tests, by just their very nature, have certain amounts of false positives, false negatives, and this is just part of the course, that there will be some small numbers of misdiagnosed or missed cases. So I guess I would just encourage, referencing CDC, the Minnesota Department of Health. We have some really strong, credible resources to help counter that if people are encountering what seems like maybe misinformation or rumor mongering in the social media sphere.
And different tests some are more effective than others too. I mean, it just depends on how that test
Right.
is getting done. Well, I think
That's right.
In the interest of honoring everyone's time, we'll wrap this up. Thank you, Tracy, so much for this comprehensive look both at epidemiology and the current situation on COVID-19. And thank you all for